Welcome, everyone. We'll give a minute or so for people to join. Good morning, good afternoon, good evening, everyone. Welcome to today's uh, EPI-WIN webinar, which is on data to action, understanding how WHO's global surveillance on coronaviruses informs response. Thank you all for joining, especially those of you who are joining where it's early in the morning or very late at night. We particularly appreciate your interest. Uh, for those of you who are new to EPI-WIN, it stands for WHO Information Network for Epidemics. The idea of EPI-WIN is to make evidence and science informational, accessible, and relevant for everyone, so that both decision makers and everyone else can take evidence-informed actions in health emergencies. So today we have an exciting line of speakers. We will have Dr. Maria von Kerkhoff. Unfortunately, she could not be here in person, but she sent a recording to welcome all of you. Then Dr. Sophie von Dobstutz, who leads the who's in global respiratory threats here at WHO, will give you an overview of the current, past, and future coronavirus threats. Then we'll hear from Aisha Akma and James Richard Otieno on how WHO monitors the current COVID-19 situation. And we'll hear from Dr. Bart Hagmans on informing action on COVID-19 vaccine antigen composition. We will hear more about how decisions on vaccination are being taken and the work of the Strategic Advisory Group from Annalise Wilder-Smith. And finally, we will hear about from Soshana Golden on the current status of COVID-19 vaccination programs. As always, we welcome you and we'd like to hear from you. So if you have insights, please write it down in the chat. Please introduce yourself as well and where you come from. It's just wonderful to see how we have people from all over the world coming together for this topic. This session is being recorded and the recording will be shared with you on the website as soon as we can. Finally, one final thing, we're here to learn, to share experiences. So please keep your comments positive and respectful, and also to the topic. Anyone who says anything disrespectful will be removed, but I hope we won't. We're here together. Also, please put your questions, and we love to hear from you, in the Q&A box. While you introduce yourself and share your insights on the chat, your question should be in the Q&A box so that we can track it and our experts can answer them at the end. And with that, I now will share the welcome remarks from Dr. Maria van Kerkhoff.
Hello, everyone, and a very warm welcome to this important webinar. My name is Maria Van Kerkhoff, the Acting Director of the Department of Epidemic and Pandemic Management at WHO headquarters in Geneva. I am delighted to see such a rich, diverse group of participants joining us today, representing a wide range of countries, roles, and background. Today, we will be showcasing the critical role and core responsibility of WHO in global surveillance and risk assessment of coronavirus threats, and how these efforts translate into real-world impact by informing vaccination strategies. Since the beginning of the 21st century, the world has faced a series of significant coronavirus outbreaks, beginning with the emergence of SARS-CoV-1 in 2002, followed by MERS-CoV or MERS coronavirus in 2012, and most recently, the global COVID-19 pandemic in 2019. Each of these events has reinforced the need for strong surveillance and risk assessment systems to help us detect and respond quickly. The COVID-19 pandemic in particular marked an unprecedented global health crisis, economic crisis, and security crisis, showing us just how vital it is to have agile systems that can adapt to evolving and persistent threats. While the crisis of COVID-19 has largely passed, new SARS-CoV-2 variants continue to emerge, and the ability to monitor, analyze, prevent, and respond remains essential to protect people around the world. WHO plays a critical role in working with member states and partners to coordinate global response to outbreaks and pandemics. From issuing timely alerts, to issuing technical evidence-based guidance, to facilitating data sharing and risk assessment, to supporting national health authorities and strengthening national health capacities, WHO is instrumental in preventing outbreaks, managing risks of pathogens with epidemic and pandemic potential, and mitigating the spread of disease. We bring together scientists, epidemiologists, clinicians, public health experts, and more to assess risks and recommend evidence-based actions. We strengthen global surveillance networks by strengthening countries' abilities to detect emerging pathogens early and share critical information quickly. We support capacity building, supporting member states to strengthen laboratories, train health workers, prepare contingency plans, and deploy medical countermeasures. Importantly, the data that comes from surveillance systems is used to inform COVID-19 evidence-based vaccination recommendations and strategies. WHO does this through the support of formalized technical advisory groups, including the Technical Advisory Group on Vaccine Composition, or TAG-COVAC, and the Strategic Advisory Group of Experts, or SAGE, on immunization policy recommendations. These groups play a critical role in reviewing emerging data, assessing risks and benefits, and shaping global recommendations that ensure vaccines are deployed effectively and equitably. You will hear from them today. Today's webinar is an opportunity to deepen our understanding of these important functions and to explore how we can work together to strengthen global health security against coronavirus threats. Thank you so much for your participation, and I'm sorry I'm not there live with you today as I'm currently on duty travel. I look forward to hearing more about this rich and engaging webinar. Have a great webinar.
So that was Dr. Maria van Kerkhoff welcoming all of you. Now, before we go on to our technical session, we'd like to hear more from you, from all of you. So, as always, we have our Slido. And our first question is that we want to learn about you. Tell us about your background in one word. That's the first question. So you go to slido.com, hashtag 2187319. So that's slido.com, hashtag 2187319. So first, we'd like to hear from you about your background. And then we have a question for you after this. But first, about you. There's virology, there's epidemiology, there's nursing, there's patient safety, vaccinology, pharmacology, maternal medicine, public health. A lot of epidemiologists here, public health specialists, a lot of lab persons as well, microbiology, uh, public health, bioterrorism specialists as well. Okay. Surveillance anthropology. Community nursing. Excellent. Someone who's transitioning into public health. I hope this webinar helps you and other EPI-WIN webinars. You have border guards, veterinary medicine, which is excellent for One Health. Right. Okay. We have 88 responses. Come on, we'd like to hear from more of you. Wonderful. We have someone from a NITAG as well. Okay. So this question is still open, but I'm now going to move to the next question, which is, how do you mostly inform yourself on the respiratory disease situation in your country or area? We have select the one that applies most to you. Do you visit national government, CDC or WHO websites? Do you watch or read the news? Do you talk to medical staff? Do you hear it from the family? Social media, maybe? Okay, most of you get it from national government, CDC or WHO websites. That's excellent. So we have the top 3 options are, it's from what we can see from here is national government, CDC or WHO website, and then from watching or reading the news and talking to medical staff. But the vast majority, and that's good to know for us as well, that you also come to the WHO website. So I will leave the Slido open. So throughout the webinar, please go and put your response down. This really helps us because it gives us an idea of what you're interested in and what you do. And it helps look at our work to better serve you. So this is very important for us. But in the interest of time, I will now stop sharing my screen. And I would like to invite Dr. Sophie von Dobschen to please talk to us about the technical session with an overview of the current, past, and future coronavirus threats. Over to you, Sophie. The floor is yours.
Thank you very much, Supriya, and a warm welcome to everyone. Can someone please put up the slides for us? Thank you. Next slide. So today's webinar is focused on, no, this is not the first slide, sorry. Can you, yes, no, stop. I need the phylogenetic tree. Yes, thank you so much. Yeah, today's webinar is focused on coronaviruses, which is a large family of viruses, and they are widely circulating in humans, but also in mammals and in birds. The human coronaviruses are mainly from the alpha and beta coronaviruses subgroups. And if you look at the phylogenetic tree here on the right, it shows the genetic similarities of these viruses. And those circled in green generally produce mild symptoms of the common cold, very similar to influenza viruses, and circulate in adults and children worldwide. If you look at the top, the viruses circled in yellow, they are the ones with epidemic and pandemic potential. So Middle East respiratory syndrome coronavirus, or MERS-CoV, is on the right, and it's a virus transmitted between camels and humans, which has been responsible for huge outbreaks in the past. On the left, you see the severe acute respiratory syndrome coronavirus, or SARS-CoV-1, which was responsible for the SARS epidemic in 22, and SARS-CoV-2, well now known for its responsibility for the COVID-19 pandemic. Next slide, please. Sorry, yeah, perfect. Oh, the timeline, please. If you go back. Yes, thank you. So indeed, the COVID-19 pandemic is not the only coronavirus threat that we faced in recent decades. And if you look at this timeline, you will note that about every 10 years or so, the world had to deal with a coronavirus emergency. And given the ability of these viruses to genetically change and evolve, there is also a constant risk that we might face a novel coronavirus emerging in future. And this is why WHO is closely monitoring and analyzing the global coronavirus situation all year round. Just to go a little bit into these different threats from the past. So in 2002, we had SARS-CoV-1 spreading fast and wide and causing the death of around 10% of the people who got infected. And thankfully, the epidemic ended and the virus seems to have disappeared. It wasn't found anymore. But then about 10 years later, MERS-CoV emerged in humans. Actually, analysis of historic dromedary camel samples showed that the virus had already been present in these camels much earlier, but the first cases were detected and confirmed in 2012. And MERS cases are actually reported until this date, and we still do not have any targeted vaccines or therapeutics available. And then, of course, well known to everyone, the COVID-19 pandemic in 2020, which is the most recent and most dramatic coronavirus threat of our times. And SARS-CoV-2 also continues to circulate in all parts of the world still and evolving constantly and giving rise to new variants. Next slide, please. Just, yeah. And also our strategic direction of coronavirus disease threat management continues to evolving. We are now moving out of the emergency phase of the COVID-19 pandemic and building on these previous COVID-19 strategic preparedness and response plans. We're shifting from emergency response to more sustainable and comprehensive management of COVID-19. To include it in our broader respiratory disease prevention control programs. And that's happening at national, regional, and global levels. The Global Coronavirus Program was created earlier this year and now consolidates WHO's work on COVID-19, MERS, and SARS, and we would be dealing with any future emerging coronavirus of public health importance as well. Next slide. So WHO's coronavirus program is organized around the 5 C's of the, oops, can you go back? Thank you. The 5 C's of our HEPA framework, which are collaborative surveillance, community protection, safe and scalable care, access to countermeasures, and emergency coordination. And we're in our strategic and operational plan, where you can find an at-a-glance document online, and the link will be shared in the chat. You can read up on our 4 main strategic objectives, which are mainly around sustaining the gains made during the COVID-19 pandemic and in the past, integrating coronavirus disease threat management into the broader respiratory threat management, enhancing our core capabilities, and generating, sharing, and applying evidence to close knowledge gaps, and also research translation. And a bit of that we will touch upon with our presentations today. Next slide, please. So realizing that a lot of the crucial work that WHO does remains invisible to the public eye, we are now very excited today to give you a peek into some of our routine activities And also with the winter season approaching in the Northern Hemisphere, we thought that you will appreciate information on how decisions around COVID-19 vaccines and vaccination are being made, and also where you can find relevant information on our website. And really, really pleased to see that most of you actually consult our website for this kind of information. So on this slide, we see today's agenda in a slightly different look. It follows a scientific process that we take to generate the data used for evidence-based decision-making and national planning. And WHO is supported in its work by several advisory groups comprised of independent experts that help us issue recommendations after considering all the available evidence. So we will start our round of presentations with Aisha Achma, who's epidemiologist in the Global Coronavirus Program, and James Otieno, a bioinformatician and genomic epidemiologist in the Emerging Threats Diagnostics and Laboratory Biosafety Unit, both here at HQ. And they will take you through WHO's multifaceted and complex global surveillance mechanism and also explain how we evaluate viruses according to a framework that we established. Then we will have Bart Haarmans, who is a virologist at the Erasmus Medical Center in the Netherlands and is the chair of our technical advisory group for COVID-19 vaccine composition. He will show you how this information that we generate and other data is being used for decision-making on vaccine composition. Following on, we'll have our colleague Annelies Wilder-Smith, who is the Executive Secretary of the Strategic Advisory Group of Experts on Immunization. And she will provide you insights into the next step. That means strategic thinking and decision-making around vaccines and vaccination. And last but not least, we'll have our colleague Shoshana Goldin, Technical Officer in WHO's Medical Countermeasures Unit, who will close off with a report on the global status of COVID-19 vaccination programs and all the available resources to support such programs, which we will also put in the chat. So thank you very much. And now over to you, Aisha.
Thank you, Sophie. Sorry, before we go on to Aisha, I just want to quickly say there are a number of you who've been asking about interpretation. I'm afraid today we have not managed to have interpretation for the webinar, but once we put the recording on our website, we will try and make sure that there is transcription in other languages as well. My apologies for that. We do our best to have interpretation as frequently as possible, but it has not been possible this time. But we will try to do something when we put it up on our website. Thank you. And over to Aisha. Apologies for interrupting.
No worries. Thank you very much, Sophie and Supriya, and hi, everybody. So I will mention about the COVID-19 surveillance, and it requires a comprehensive surveillance with complementary surveillance approaches, and which is in line with the Mosaic framework. And the Mosaic framework is published in 2023 by WHO, which is emphasizing the need for multiple surveillance systems and complementary studies to fully understand the risks and the impact of respiratory virus diseases. So our COVID-19 surveillance recommended for countries to really be in line and based on the Mosaic framework. So this pyramid here we see is kind of illustrates how countries are monitoring COVID-19. At the baseline level, from a broader reporting perspective, most of the countries have the responsibility to report re-emerging known coronaviruses or suspected novel coronaviruses under international health regulations requirements. And if we go one up, we see that many countries also integrated SARS-CoV-2 into broader influenza surveillance systems. And then there are fewer countries who are reporting also some burden indicators like hospitalizations, ICU admissions, and deaths to WHO and industries. There are fewer countries who are also reporting the wastewater surveillance information or animal surveillance, and fewer countries are still conducted some clinical surveillance networks, spatial studies, or are part of the coronavirus network. It's a specialized laboratory reference laboratory network. So this parameters illustrates that the number of activities in a country can increase to have a more complementary serves. So the countries can implement multiple surveillance approaches, and of course they can coordinate this multiple surveillance systems to well match to their specific respiratory virus objectives. Next slide, please. I don't see the next slide. This one. Thank you very much. So as it is recommended for the country level, at the global level also we gather information from different surveillance systems. And the list you can see on the left side, the framed ones that I will mention briefly, and the unframed ones will be mentioned by my other colleagues during this webinar. But of course, in any global surveillance system, the member states are the most critical element. They are the ones who conduct the surveillance, generate data, and share it with the global community. So without their commitment and collaboration, such global surveillance system wouldn't be possible. So member states are truly the backbone of the global surveillance efforts, especially for COVID-19. And we deeply acknowledge and appreciate their efforts on this. So this figure shows how data flows from member states to regional offices or global influenza surveillance system, or in open data systems like GSAID or EGRF, and then how it is triangulated in COVID-19 dashboard as data elements. You can see the listed here, from cases and deaths to circulation or variant distribution, and there are different output types that you can see these data elements as epidemiological summary, figures, maps, or metadata or downloadable statistics. Next slide, please. So we really aim to create a unified platform for COVID-19. In this dashboard, we wanted to integrate and triangulate of the latest global data and insights on many different components of COVID-19, which includes the circulation, cases, deaths, hospitalizations, vaccines. Wastewater surveillance sources are at the same platform that you can go and look for the same country. We also have another coronavirus dashboard, for MERS coronavirus dashboard, which was also subject to another EPI webinar in the past. Next slide, please. Yes, so the in addition to this global COVID-19 dashboard, each regional office, they have their own information systems and dashboards. And for most of them, they integrated their COVID-19 SARS-CoV-2 surveillance with other respiratory viruses like influenza and RSV. They're still being updated actively. Western Pacific region is an exception, with the COVID-19 situation reports very specific to SARS-CoV-2 being published bi-weekly. And you can find more detailed information sometimes for relevant countries in these dashboards. I really recommend for you to visit them. Next slide, please. So as if you remember the list of the surveillance approaches that we mentioned a few slides before, I think integrated surveillance is one of the most important ones. And countries are really encouraged to integrate SARS-CoV-2 into their existing respiratory disease surveillance system. And for most of the countries, it is the Global Influenza Surveillance and Response System, which is led by the Global Influenza Program. And currently, 77% of WHO member states have adopted this and reporting SARS-CoV-2 surveillance data through the expanded JustRisk platforms. Next slide, please. And another surveillance system was the detailed surveillance. When we say detailed, actually we mean the health impact data is going beyond the circulation, and we are looking at the trends in the hospitalizations, ICU admissions, number of deaths, but not just number of deaths, the deaths by age. We also have some severity indicators. We are looking at the number of deaths per 1,000 hospitalizations or number of ICU admissions per 1,000 hospitalization. And this impact data is very important to understand the burden of the disease and and they monitor the severity of the disease, not directly associated, but indirectly, especially for emerging variants. It's really one of the elements that we use for the variant risk assessment as well. Unfortunately, it's very quite limited, as you can see from the map. The data is coming from some parts of the globe. Next slide, please. So the wastewater environmental surveillance was also in the list. As you can see on the left, we have a section in our dashboard on the wastewater surveillance sources, which are the countries are sharing their routine wastewater monitoring information in publicly available websites. And this is a source available to everybody in the dashboard in a consolidated way at the global level. Of course, there are a limited number of countries who are doing that. And internally, we analyze this data as we are looking at the concentration levels and the trends, if they're increasing or decreasing circulation of SARS-CoV-2 in the wastewater. And sometimes, which is very valuable, also some countries are also analyzing the variant distribution in their wastewater. Next slide, please. So event-based surveillance also is an important factor. This is not based on the data reporting directly to WHO, but we conduct it generally in two ways. First of all, visiting the official country public health institution websites. They're very resourceful. There are some dashboards, situation reports, spatial reports, and statements in those sources. And we also do a media monitoring, and we mainly do it via a platform called EPI-WIN. In open, it means Epidemic Intelligence from Open Sources. So this is a kind of platform website that you can create algorithms, and for the specific subjects that you are looking for, you can have access to articles in the media or in social media, for source information. So this is led by WHO, but it is not limited use for WHO. It can be used by other public health actors and being used by other public health actors worldwide. Next slide, please. And for the animal surveillance, of course, animal surveillance isn't part of WHO's mandate, but the collaboration with the organizations who does animal surveillance is quite essential for WHO, because many zoonotic diseases can spill over to human and cause pandemics. So the WHO closely monitors that human-animal interface. And for example, in March 2022, WHO with Food and Agriculture Organization and World Organization for Animal Health altogether published a joint statement on the prioritization of monitoring SARS-CoV-2 infections in wildlife and preventing the formation of animal reservoirs. And FAO, which is the Food and Agriculture Organization, routinely publishes updates on the emerging zoonotic coronaviruses in animals. So this is an output that we follow closely, and we collaborate with them still. Of course, this collaboration didn't happen only after COVID-19. Before SARS-CoV-2 emergence, these organizations were collaborating already. In 2019, there was a tripartite zoonosis guide published, which is followed by the publishing of an operational tool for the surveillance and information tool. Then this tripartite is evolved to quadripartite with the involvement of the UN Emergency Environment Program, and they have altogether published the One Health Joint Action Plan. Next slide, please. So yes, I think this slide is summarizing what we do with all these surveillance activities. And of course, we use all this information to create evidence-based guidelines, reports, and risk assessment. And of course, as the subject of this webinar, I'm here sharing only the guidelines. Considering the surveillance, one of the most important surveillance guidelines for the moment for SARS-CoV-2, we can say that prepared by the Global Influenza Program for the integrated surveillance. It's a kind of standards and operational guidance for countries to integrate other respiratory viruses, including SARS-CoV-2, in the influenza surveillance systems. Besides this, we also in 2024, we published updated COVID-19 policy briefs. These documents are targeted to higher level policy producers in countries and surveillance one of the 6 topics doing recommendations to policymakers. We also developed wastewater surveillance guidelines for SARS-CoV-2, but also multi-pathogen approach for prioritization of pathogens for the countries' use. And most importantly, we use this information. We have COVID-19 global risk assessment, which we conducted and published publicly every 6 months. And when the need arises, SARS-CoV-2 variant risk evaluations, which James will explain in more detail. Next slide, please. But there are some key areas for strengthening. Of course, as you can see on the maps on the right side, we see the maps for the reported hospitalizations, or in the bottom that we see the SARS-CoV-2 variant second submissions. The bottom line here that there are some geographical gaps here. So the evidence-based decision-making and guidance development and risk assessments are highly dependent to the information coming from this limited geographical areas and high income context. So this is a point that is a big limitation and an area to strengthen, and countries from those underrepresented regions are really encouraged to monitor the burden of COVID-19 and SARS-CoV-2 variant distribution, and as well as share this information with global public health community. Next slide, please. So, of course, these limitations and the areas of strengthening to address all these issues for non-coronaviruses, but as well as the kind of facilitating the early and accurate detection of any novel coronavirus threat, WHO transformed the existing COVID-19 reference laboratory network to a more specialized coronavirus network, as you can see in the middle map. In 2024, this network consists of 34 laboratories from 21 countries. They're human health laboratories, animal health and environmental surveillance laboratories. So this is One Health approach are being involved, and activities already started in 2024, 2025. The main objectives are really to facilitate an early accurate detection and to provide timely risk assessment, as well as the support capacity building in the laboratories, particularly in low and middle income countries. So now I will give floor to James and continue to more detailed information on genomic surveillance. Over to you.
Thanks, Aisha. Next slide. So as Sophie alluded in her first slide, these viruses continue to evolve. I mean, that's what viruses do as part of, the experience with the challenge with the immune systems in which they live. So SARS-CoV-2, the graph on the left shows the evolution of different SARS-CoV-2 variants. So these are the ones that have been assigned different Greek names. On the y-axis, you'll see the number of mutations from the index, also called the Wuhan strain. And you'll see that, there's increasing number of mutations up until XFG, which is the current most prevalent SARS-CoV-2 variant in circulation at this time. And with this evolution, as viruses evolve, we need an early warning system that can give us a proper understanding of what characteristics the new variants have. And to this end, WHO did develop a framework to assess the SARS-CoV-2 variants. And with this, we are able to assess the risk posed by these different variants. And this framework was published in August 2023. A lot of the work that goes on behind the variant risk assessment of this SARS-CoV-2 variants is driven by WHO and also supported by the Technical Advisory Group on Virus Evolution that I want to talk about on the next slide. So the Technical Advisory Group on Virus Evolution, in short TAG-VE, is an independent multidisciplinary advisory group that assesses the public health implications of priority viruses and informing on WHO policy. So here, note the priority viruses, and this means that the work of TAG-VE has also evolved, pun intended, to go beyond SARS-CoV-2 and now includes other priority viruses. So ideally, the function is to determine which variants warrant further investigations, and for the variants that have been identified to assess for assessment, we look at whether these variants do alter transmission or disease characteristics, or whether they alter the performance of vaccines, therapeutics, and diagnostics, and also whether they do alter the effectiveness of public health and social measures. On the right here, you'll see some of the outputs that we've had from this tag in 2025. For example, here we've published the MERS-CoV risk evaluation. This is the latest publication from TAG-VE. We've also had risk evaluation reports for Mpox, both clade 1A and 1B. SARS-CoV-2, this just lists the most recent ones this year, LP81, NB181, XFG, as well as Oropush that was published in June. Next slide, please. So this is a sample of risk evaluation for SARS-CoV-2 variant XFG. And typically the workflow involves looking at the surveillance and genomics indicators. And once we aggregate this information, we take this through an expert review. And once this has been discussed primarily with the TAG-VE, we develop a risk evaluation document that looks similar to this. Even though this now, of course, with the expansion of that framework to other priority viruses, it looks similar, but there's small differences because different viruses, the different viruses have some differences between them. Then, we do publish the recommendations as well as publish this, on the TAG-VE webpage. Next slide, please. So still talking about SARS-CoV-2, you will know that we have different categorizations for these variants as we assess them. And from the left to right, the leftmost VUM, or variants under monitoring, being the entry point. And here you'll see that definition is quite simple. So this is a variant whose genetics changes are suspected to affect characteristics, and but has some early growth signals in comparison to other co-circulating variants. So you'll notice that at this stage, a lot of these changes are just suspected. But then there are clear signs of relative growth in comparison to other variants. And then as we transition to VOI, this is where we have a bit more information with regards to how these genetic mutations do affect the characteristics of the variant. And we are also seeing growth advantage in more than a single WHO region. So at this point, we're expecting more broad spread of this particular variant. And for a VOC, which is our highest criteria, so it would meet the VOI definition, but then it would also have additional effects, for example, having detrimental changes in clinical severity, change in epidemiology with substantial health system impact, and also significant decrease in vaccine effectiveness. At this point, we don't have a VOC. I mean, we still have the same VOC Omicron that was designated a couple of years ago. And for VOI, we have JN.1, and the VUMs that we have are actually descended lineages of JN.1. Next slide, please. So again, just highlighting this tracking of the different variants and the work that goes on in the risk assessment. Here again, just highlighting some of the the variants that have been evaluated. In SACO, we have VOI, which is on the 1GN1, and in the square box, we have the VOMs, and then with the colors showing the different events when a variant was actually assigned as a VOM, when a risk assessment was done, when also like when it was de-escalated. That means like the circulation had decreased below 1%, both at a global level as well as across all the WHO regions. However, some of the challenges that we do face with some of this work is lack of crucial studies, such as those that are able to assess the severity of the different variants in the different populations. But we try and make do with the data that is available. But it's good to note that that some of these challenges do hamper the work that is that goes on around these specific variants. Next slide, please. So for the genomic data, we do have data from GSAID as well as additional curated data from COV Spectrum. Then we do summarize this data internally, and then this feeds into, for example, the COVID-19 dashboard that I usually talk about. Of course, the work that TAG-VE does, and some of the work that also some of the information that TAG-COVAC uses for its decision making, that you'll get to hear about on the next talk. Next slide, please. So I'd like to finish with this slide just highlighting some of the challenges especially with regard to the genomic data. As I've painted the picture that these viruses continue to evolve, and we've implemented early warning signals to understand them or have a better understanding of how they're evolving and the impact that they might have on different indicators. But at the same time, we are cognizant of the fact that, there's reduced genomic data, there's a reduction in the number of member states that are sharing the data. And if you compare the data from 2022 and 2023, the data for 2024 will be released sometime this year. You can see that, we are having a decrease for all the regions here. And if you now even look into how many of those member states that actually did share genomic data shared that data consistently across the year. If you look at your far left, so this would be the yellowish color, you can see that in 2022, we had slightly more than 60% of the countries sharing data consistently between 10 and 12 months of the year, and this has significantly reduced to just slightly above 40%. So here we are not really just advocating for the number of sequences, but more also about the representative of how that data is, because again, we hope not to have blind spots from particular regions that we can only be able to assess the data if we also receive it quite early on. So this is my last slide, and I think then I need to hand over to Rebecca. Over to you. Or is it Pat?
So I will take over. Thank you so much, James. So I'm Bart Haagmans. I'm a virologist at Erasmus MC Rotterdam, working on coronavirus from 2003. So I'll introduce the TAG-COVAC, which is the Technical Advisory Group on COVID-19 vaccine composition. Next slide. Try to be a bit quick. We are a bit behind schedule, I think. So I think it's important to mention, and you all know this, that the COVID vaccines have been developed and implemented very quickly. Not only that, they also provided high protection against, especially against severe disease, but also against infection. I think this was a major achievement. The problem is that, and that was already shown by James, that SARS-CoV-2 evolved and continues to escape this vaccine-induced immunity, especially the Omicron variants. And so there's another problem is that in time, the vaccine-induced immunity wanes. So there are two problems. So the solution is actually to give a boost, and to give a boost with an updated variant antigen. Next slide. So this is actually, next slide, next. So this is actually the work of, go back, sorry, it was only the box. This is actually the work of the TAC-COVAC, which assesses the, the impact of the SARS-CoV-2 variants on current COVID vaccines, and then tries to come up with an assessment of and a recommendation of potential new antigens. So the TAC-COVAC consists of 16 members, and this is a broad expertise, immunologists, virologists, people that know something about modeling, but also public health experts. Next slide. So they need to bring together the data, so look at the methods used and also make an interpretation of the available data. And partly that is data that James presented already, but also more on that, and I'll come back to that. And using that analysis that is needed to recommend to WHO actually adaptations, if needed, to updated vaccine. So do we need another antigen for the vaccines to come and for the next year? And this is similar to what we have seen for influenza. So influenza, you also have updates every year. So the meeting frequency of this committee is actually twice per year. Next slide. So this is an important slide which shows the phylogenetic relationship of the variants that were discussed earlier in a graphic way. And it shows the actions of the TAC-COVAC in advising updates for the vaccine. So in the lower part, you see that the first update recommendation was actually on including the Omicron variants, the early Omicron variants, BA1 or BA4-5, combined with the index virus, so that's the Wuhan original vaccine virus, to update the vaccine in June 22. That was followed by updates in 23 and 24, respectively on the XBB.1.5 monovalent vaccine, so it's only XBB.1.5 antigen, and then followed by the JN1 vaccine that was used previously in 24. So earlier this year, the committee actually recommended to use another antigen, and that's the LP81 antigen. So that is actually the antigen used now. And I should say that actually this morning I went to Amsterdam and had a shot with this updated vaccine. So hopefully it works. And what means it works? It should work not only against LP81, but more importantly, induce broader protection. And here you can see in red and orange variants that circulate at the moment. This is the XFG, for example. So the idea is that the updated vaccine can induce broad protection against circulating variants at the moment, but hopefully also to variants that pop up in the future. Next slide. So as said, the TAC-COVAC needs to consider all kinds of different data to make a recommendation. And the first type of data is, going back to James and Isa, is knowledge on the genetic evolution, which variants are circulating. And that's depicted here. So we can see that the LP811 in orange is just a minor variant. It has been replaced by two dominant variants XFG and EPI-181. So this is the continuous evolution of these variants. So it's very difficult to get a prediction of the antigen used at that time. You're always a bit behind. But still, the idea is that by updating, you still protect against these novel variants. But this information is really crucial to know which variants are circulating and how they differ genetically. Next slide. More importantly, it's to know what the antigenic differences are. And basically, there are two methods. One is to generate antisera in animals and make so-called antigenic maps. And one example is shown in the middle, in the lower part, by graphical displaying the antigenic difference between these variants. So there are three clusters, and on the right you see the yellow, orange, red cluster. These are the more recent variants that are now circulating. They cluster quite close, meaning that an antigen used in this cluster as a vaccine can protect quite well against new variants. So hopefully the new variants will still cluster here and not to a cluster which is far away. Next slide. More importantly, you can use sera from humans that are vaccinated and test in vitro the neutralization capacity. So on the lower panel, you see, for example, vaccinees with the JN1 vaccine. They neutralize JN1 quite well, but on the right in blue, the XFG levels are much lower. This means there is escape. So this is an indication that you may need to update the vaccine at a certain point. Next slide. Of course, I showed that there were many updates already, so we have data on these vaccine effectiveness of these earlier variants and the ones that are used, for example, last year, the JN1. And we can estimate now also the vaccine effectiveness of these vaccines. And this is important to assess how effective are these updates actually and how they affect protection against severe disease, but also against infection. So this is important data to consider in this committee. Next slide. Finally, the vaccine manufacturers, of course, are working on the novel updates, and they have data which could be interesting to the committee to consider the antigenicity of the vaccines at an early stage. So we get also this information. Next slide. So this all comes together in a decision-making meeting in December. So we have now one in December, and the idea is here to come up with a recommendation either to keep the antigen or to update. So this is the statement that will be published in December and is accompanied by an attachment with all kind of data that are used, which actually support the statement that is made by the Tech COVAC. And with that, I close. Thank you.
Let's now turn to the topic of informing decisions on vaccination and specifically the role of the Strategic Advisory Group of Experts on Immunization, commonly known as SAGE. Most of you will be familiar with SAGE. It was established in 1999 and endorsed by the World Health Assembly. SAGE serves as a principal advisory body to the WHO on global policies related to vaccines of public health importance. Next slide, please. With the growing complexity of global immunization challenges, WHO's and SAGE's roles in shaping immunization policy are more critical than ever. In the context of the WHO's 2025 strategy, particularly also during the recent restructuring and downsizing efforts at WHO, the SAGE work has been highlighted as a core function, reaffirming its central role in guiding vaccine use globally. And the key attributes really of this normative function that we play as SAGE with the RITEX and with the NITEX include transparency, remaining independent, using the best available evidence, developing very robust evidence to policy making, and then supporting countries. And this role was also highlighted in a recent Lancet article that you see on the left. Next slide, please. In the next few slides, I'll walk you through some of the SAGE's methods and processes, because I think it's important to understand the rigor behind our work. So we have working groups that are subservient to SAGE, that consist of subject matter experts. And we then identify the critical questions, we do the systematic literature review, we do a risk of bias assessment, and apply grade principles. With that, then we develop evidence and recommendation tables, draft recommendations, present those to SAGE. And the SAGE meetings take place twice per year. And at that stage, we discuss the draft recommendation presented by the SAGE working group, and then make a decision that then goes to WHO Director General, who then endorses this, and then it will be published as a so-called WHO vaccine position paper. Now, with the many changes that we saw with, obviously, with during the epidemic, we did not come up with a position paper, but with interim recommendations that were updated very frequently. Next slide, please. So just again to highlight the rigor, this is the grade approach. So you formulate the question, the PICO question, you select the critical outcomes, you do a systematic literature review, you create evidence with grading, and the quality of this evidence is then, as I said, graded. And it can be graded as high, moderate, low, or very low. So it can be graded or up, it can be graded upwards if it can be graded downwards. For example, if there's a risk of bias or inconsistency or indirectness or imprecision of the data or publication bias. It can also be graded upwards if there's a large effect or a large dose response effect. So with this, you grade it, and then that's done with a panel, and then you develop the ETR, which is the evidence to recommendation framework using the grade. And with that, then you come to the recommendation. So the evidence to decision table criteria address the following 7 criteria. You have the public problem, so you have the public health problem, the problem statement, the benefits and harms that always require grading, values and preferences, resource use and cost effectiveness, equity impacts, acceptability, and feasibility. With all this, you balance benefits and harms, and then you come up with your recommendations. I just wanted to give that background to you so you understand the whole process that is behind every single SAGE decision. Next slide, please. Obviously, SAGE does not work in silo, but works with relevant committees. And we just, for example, TAC-COVAC, we just had a presentation by TAC-COVAC, but also with GACS, that is the committee at WHO in charge of vaccine safety, and various other committees, including working with regional consultations, and then and obviously with countries. Next slide, please. So SAGE's interim recommendations for COVID-19 vaccines have undergone multiple iterations over the past years and were discussed at multiple SAGE meetings. We looked through the evidence for at least 9 different vaccines that were recommended during that time. And remember, when vaccines first became available towards the end of 2020, vaccine supply was still limited, and therefore SAGE issued guidance on prioritization, identifying 3 main priority use groups: high priority, moderate, and low priority. We also address subpopulations for special concerns, such as pregnant women, immune-compromised individuals, and health workers. And this is now the roadmap here by 2023, which is still valid and still holds true as highlighted in the recent SAGE meeting. So by 2023, we had widespread population immunity, and we reassessed the need for vaccination or booster doses across those 3 groups. And you see that SAGE still recommends continued revaccination for high priority use groups with a 6 to 12 months interval if you're very, very vulnerable, or a 12-month interval for the other older adults. While some benefit still exists for revaccinating other priority use groups, by 2023, SAGE already concluded that from a programmatic perspective, doing so is less cost-effective and has lower public health impact. Therefore, countries may consider revaccination of these groups, so the moderate to the low groups, only in light of other public health priorities and cost effectiveness. So since 2023, SAGE does not recommend programmatic revaccination in these groups. And next slide, please. So here you also see the low priority use groups. These are children where we do not recommend a revaccination anymore. But for the target population of special interest, this includes the pregnant women. Vaccination during pregnant women is still recommended, ideally in the late second trimester, for 3 reasons: protecting the pregnant woman, 1; 2, preventing adverse pregnancy outcomes, 2; and 3, providing protection for the infant up to 6 months of age. SAGE also still recommends revaccination of health workers. For immunocompromised individuals, revaccination decisions should be made on an individual basis in consultation with the clinician. And now, next slide. Now we are obviously 5 years into the pandemic. And at this stage, we have seen even further substantial decline in COVID-related deaths and ICU admissions. In response, SAGE is currently re-evaluating the roadmap. So we are currently in the process of updating the roadmap that I just showed to you. And we are addressing this by asking the following policy questions and then using our usual rigorous process. So should we still continue recommending the 12-monthly boosters to high priority? Should we even still give a 6-month interval to the very vulnerable? Should we still vaccinate health workers? Should we still offer a single dose during each pregnancy? And should WHO continue to not recommend annual boosters for medium and low priority use group? Next slide. And to do this, again, we go into the same process. And this is the PICO question: do we revax? So the question is the revaccinating with the current variant adapted vaccines versus not vaccinating in the past year. And we're going through all the evidence. We have commissioned systematic reviews. We have commissioned risk of bias assessments. And then we will rate again and for the grading. And next slide. And then we will have an updated roadmap that will be deliberated upon at the next SAGE meeting. So that will be in March 2026. And that will then result in the position paper. And with this, I would like to thank you and hand over to the next speaker.
Thank you so much, Annelies. Can we move to the next slide, please? Wonderful. I'm Dr. Shoshana Golden. I'm a technical officer in WHO's Medical Countermeasures Unit, and I'll be speaking briefly about the global status of COVID-19 vaccination programs and some key resources available to support countries, communities, and individuals. Next slide, please. First and foremost, I want to reiterate this core message about COVID-19 vaccination being our most important resource as we prevent and mitigate annual morbidity and mortality. With that, WHO and UNICEF work together to collect information through the Joint Reporting Forum on Immunization from countries about COVID-19 vaccination, in addition to many other vaccines. Through this data source, we have annual information accessible on the use of COVID-19 vaccines, as well as on policy recommendations. What you can see at the table at the top of this slide is that more than 50% of WHO member states have a policy in place for COVID-19 revaccination or boosters, in line with what Annelies just explained, for older adults and for people with chronic conditions. The other populations that Annelies featured in her presentation are also included on this screen, so you can see the complete disaggregation. While we have more than half of the world recommending COVID-19 revaccination or boosters, we have a significantly smaller number of countries that are providing COVID-19 vaccination coverage data, and we have quite low median coverage for these key target groups, as you can see on the table in the right-hand and middle columns. Why is this important? As the title of this webinar says, data informs action. When member states are monitoring and reporting COVID-19 vaccination coverage data, that enables them to assess equity and access issues and to address these issues for a variety of different interventions. At the bottom of the screen, we're featuring a number of key resources that might be useful for individuals, for health facility managers, for government officials, as they think about COVID-19 vaccination in their communities and countries. We know that there might be a number of different reasons why the median coverage rate for these target populations is low. These could include supply constraints, acceptance and demand issues, or challenges with monitoring and reporting this information. To support countries in addressing this, WHO has provided campaign and other information, communication, and education resources. We are currently working on a manual that helps countries to monitor and report COVID-19 as well as other respiratory vaccination data. This also helps countries to actually analyze that data and apply it to support local targeted interventions. And WHO has provided a really fantastic number of resources, guidance, training, tools, and so much more in the COVID-19 vaccine delivery toolkit. These resources are helpful as countries think about how they can advance their programs and strengthen coverage. Because ultimately, if we want to have a measurable impact in protecting people at risk, we do need that vaccine to be used by these people who are most vulnerable to COVID-19, severe disease. Next slide, please. I'll briefly speak to this work that is being done on increasing uptake of COVID-19 vaccines, with great thanks to my colleague Lisa Menning, who is driving this work and who is available on the call to answer any questions. There are a number of resources that are available to member states so that they can assess the quantitative and qualitative reasons for lower uptake and to understand what are the enablers and barriers to COVID-19 vaccination. This information is incredibly important to provide evidence-based interventions. Those interventions should be evaluated to ensure that they are effective and can be improved. There are a number of consistent barriers that stand out when we talk about COVID-19 and other respiratory vaccinations, including the importance of high-quality services, accessibility of the vaccine, and reducing the financial implications, preferably making the vaccine free of charge to priority populations. Integrated service delivery can also ensure that people who need that vaccine are able to access it in a time-efficient way. Countries that have been really successful at achieving high uptake of this vaccine and other vaccines are engaging in two-way communication with communities and civil society to ensure that the vaccination program is locally tailored and meets the needs of the communities. And finally, particularly in this period of mis and disinformation, it's important that we have trusted champions who are providing messaging about COVID-19 vaccination, and that we are tailoring this communication to ensure that it is relevant and accessible to the populations that need it. In particular, that means making sure it's available in local languages and responding to the common mis or disinformation themes that are emerging. With that, I'll turn it back over to Sophie to guide us through the question and answer component of our EPI-WIN session.
Thank you so much, Shoshana, and a huge thank you to all the speakers, actually, and also to the participants who've been very, very active in putting questions into the chat. And so we have, sorry for going slightly over time from what we planned, but we would not like to compromise on the Q&A. And so I would like for the speakers to please turn on their cameras again so we can take some of the questions posted in the Q&A live. And maybe Shoshana, since you're the last one speaking, maybe you can be the first one addressing one of the questions we got. Despite ongoing debates about vaccine effectiveness, do you still see COVID-19 vaccination is needed for public health? Thank you.
Thank you so much, Sophie. Happy to start responding to this and to welcome Annalise as well to respond to the question. COVID-19 vaccination is our best tool, as I mentioned in the presentation, in both preventing and mitigating the annual epidemics that we see occurring. Annalise provided a fantastic overview of the priority populations for COVID-19 vaccination, where we see this tool being most useful, particularly in the current context where there are these supply constraints that we understand at the national level. So my short answer to the question is yes, COVID-19 vaccination remains a really important public health priority, and I'll turn to Annalise for her comments as well.
So I agree with you, Shoshana. So the biggest public health impact remains obviously in the high priority use groups, and that is the older people and those with comorbidities. As for pregnancy, we now see much less severe disease in pregnant women. And here the question is whether pregnant women should be vaccinated mainly to protect the infant, as we have now seen an uptick of COVID-related hospitalizations in infants up to the age of 6 months. That evidence is currently being reviewed and will be presented at SAGE, and then will come with a recommendation. Health workers is another issue where we still recommend the use of vaccines. We are fully aware that many countries, including high-income countries, have stopped offering revaccination to health workers, and we're currently reviewing the evidence to this end.
Thank you so much, Annalise. There was also a question on the SAGE literature reviews and if the information you're collecting will be accessible. Will these be published?
Yes. So one of the principles for SAGE is to use published, or at least in preprint available data, and also all the data that we do look at during SAGE is always made public.
Thank you very much. Then I saw there were some questions on the geographic representation of surveillance or not. And maybe I can turn over to Aisha to respond to that.
Sure. So it's clearly the data shared with the WHO on the maps. We can see that there are some regions are underrepresented, and we think that this is due to the deprioritization of COVID-19 and the surveillance programs and the surveillance strategies. Although many countries integrated their surveillance in the global influenza surveillance and response system, for the burden indicators and the especially genomic surveillance, we have huge gaps. It is correct. So, but the guidelines, for example, for the integrated surveillance is clearly indicated that the countries who are doing integrated surveillance from the positive samples coming from their systematic virological surveillance sites or sentinel sites, they should a good sample of it, representative sample of it, to use it to sequencing and share it with the public domains. And I think if this baseline recommendation applied in the countries, we can slightly overcome this problem, at least in terms of genomic surveillance. And the Global Influenza Program also provides countries to epidemiological data share platform, which is Flu ID, and countries also can use this.
Thank you, Aisha. Annelies, if I may turn over to you again for the next question. It is about the safety of vaccines and how we look at possible side effects, how we gauge the safety, how this is being assessed. Maybe you could speak to that as well. Thank you.
I think in principle, there's no larger data safety set than for COVID-19 vaccines now, with 7 billion and more vaccines being given. At this stage, we have fewer platforms being used. So the viral vector vaccines are currently not being used as they were not updated for the variants. So basically, we still have access now to mRNA vaccines, to protein-based vaccines, and there are still some inactivated vaccines being used. So the adverse events of special interest, obviously, for the mRNA vaccine is the myocarditis. And I'm very pleased to let you know that that the rates of myocarditis now, at the time when we are all post second dose, at a level where we already all have been exposed to natural infection, so the rate of myocarditis is now back to its background rate. So it's not increased. We don't see increased myocarditis rates anymore, according to GACS.
Thank you. And then maybe we can take a last question on TechCOVAX. So there's a question what TechCOVAX anticipates to be a recommendation for the 2026 vaccine composition. I think it's still early days, but I still want to give the opportunity to Bart to let us know when we will know. Thank you.
Yeah, so as said, we have a meeting in December. Then we look at all the available data, which includes the variants that are circulating, the efficacy against these variants with the current vaccines, the LP81. So at the moment, we are gathering data on how effective are the LP81 vaccines against newer variants, either in vitro or maybe also with data coming up from studies in humans on immunogenicity. And then we decide whether there is a recommendation for update. As it looks right now, I would say they're quite close. So mostly these updates have been made in April, May. So let's see what the outcome will be. Yeah.
Excellent, and we're looking forward to that. There were a few questions on surveillance in animals, and actually in the Q&A, I put a few links to documents that our partner organizations that work on the animal side of things, the Food and Agriculture Organization, FAO, and the World Organization for Animal Health, or WOA, have put out. So I would refer you to our partners for information on that, but we're working closely together, of course, sharing information and also issuing statements together. I'm checking on the genomic side of things. Maybe, James, I can just give you the floor if you want. I saw you addressed many of these questions in writing, so thank you so much for that. But if you want to summarize a few inputs that you were giving in writing, and then we can close. Thank you.
Yeah, I think Aisha partly has responded to that. So yes, we do have challenges in terms of the data, or rather the genomics data that we analyze. And as you've seen, this is part of the data that, TechCOVAX uses for decision making. So it's important that we track the variants as they emerge. And as Aisha has alluded, I mean, there are different challenges. So one, obviously, reduced funding, to different member states. Two, there are delayed integration into, of SARS-CoV-2 into integrated surveillance. Three,
I think we lost James. Yeah.
Again,
Oh.
we expect we'll have different, so I can hear you. Oh, I can hear you. Can you hear me now?
Yes, we lost you for a second, but glad to have you back. Please continue.
Yeah, so I was saying that, there are also different, sometimes, COVID can be
Yeah, I think
prioritize
James,
different pathogen member states. So
unfortunately,
yeah, my internet is a bit jumpy,
yeah,
so
you're
I'll
in and
stop.
out. But yeah, thank you. And I'm glad we have all your written answers at this point because it was difficult to understand you. But thank you for coming in. And with that, I'd like to hand over to Supriya for the closing. Thank you again very, very much to the speakers.
Thank you very much, Sophie, for moderating that excellent webinar, very rich and very informative, and getting different perspectives and putting it all together. Thank you very much, and thank you to each and every one of the speakers. Let me go by order of their speech, which is Aisha, James, Bart, Annalise, and Sushana. I'd also like to thank the three people you haven't seen who were in the background working on the Q&As. Sushana, Rebecca, and Vicky. Sorry. So they've been working very hard to put things on the chat, for information on the chat for you, answering some of the questions. So huge thanks to them. I'd also like to thank my colleagues sitting, you don't see them, but they're sitting in the room with me here, and they're also working in the background, Michael and Maria Isabella. They've been tracking the chat to make sure that we get your point of view, making sure everyone's sharing the slides and doing a lot of stuff on the background. So huge thanks to them as well. Finally, last but definitely not least, a huge thanks to each and every one of you for joining, for staying with us. And I hope you find this webinar informative and will use it in your work, most importantly. I'd like to also share with you that we have some exciting webinars coming up. Next week, we have a session on Rift Valley fever. Then on 19th November, you will have an introduction to the WHO Outbreak Toolkit and applications and how you can use that. On the week of 24th November is really busy. We have 2 webinars, not 1. That's because of the time sensitivity of some of the issues. One is the attributes of pathogen genomic data platforms, how they can support timely and equitable sharing. A new guidelines being brought out on that, and that will be shared with you. And on the 26th of November, we will have, again, a new document, a new information sharing event where cases of meningococcal disease have been updated, how you can define cases, and a new public health tool has been brought out, and that will be shared with you. What's new, why whatever's new has been suggested, the new recommendations, the new definitions, and how you can use it, more importantly. And finally, on the 3rd of December, we'll be launching the Public Health Intelligence Competency Framework and Curriculum, which we hope will be used for all public health persons out there and will build the future of public health intelligence, as the title says. For those of you who are not subscribers, do subscribe to our EPI-WIN mailing list so that you get all this information every week. And with that, once again, thank you very much. Huge thanks to all the speakers, everyone working in the background, and to each and every one of the participants. And please do check our website in a few days or next week for the recording. Thank you. Bye.